I'm Dr. Morie Gertz, and I'm here to talk to you a little bit about immune-targeted therapy and how it's utilized in both amyloidosis and multiple myeloma. All of us have in our body these immune cells whose primary function is to kill invading bacteria, germs, infections, viruses, and funguses. And they actually do a very, very good job in killing these infections. When a person has abnormal plasma cells, whether that's in the context of amyloidosis, plasma cells in the bone marrow, or myeloma, plasma cells in the bone marrow, for some reason, your body's immune system kind of just swims right by those cancer cells and doesn't attack them. And so your immune system, which is supposed to protect you, somehow fails and is incapable of recognizing cancer cells and destroying them the way they need to be destroyed. So technologies have been developed over the past 10 years. Now, one of the principles is recognizing that every single cell of your body has unique proteins on the cell surface that actually identify that cell. That is, once you know that protein, you actually know what kind of cell it is. Now, you're thinking to yourself, I don't even know what he's talking about. I don't know any proteins on any cells. But what if I said to you, what cell is identified by protein A? Well, you might not know what that is. And then I give you a clue. I go, some of the cells actually have on their surface protein B. And say, no, still don't know. And some people actually have protein A and protein B on their cell surface, so-called AB. And if they don't have either one of the proteins, it's called O. And of course, what I'm referring to is your blood types. And your blood types are A, B, AB, and neither. And that actually, those proteins identify red blood cells because those proteins aren't on any other cells of the body. And of course, when it was first described in 1906, they didn't even know they were proteins, so they called them types. But they're still proteins, very specific. And when you know that protein, you know it's a red blood cell. Likewise, if I told you a protein BCMA and what that stands for isn't important, but you tell any hematologist BCMA and they know that's the protein found on plasma cells. It is uniformly found on plasma cells, both in amyloidosis and in multiple myeloma. The question is, how can we use this to our advantage? Well, we know that your white blood cells don't recognize the plasma cells with the BCMA on it. And then the question is what to do and which white blood cells. There's different white blood cells. And in fact, the most important cell for killing cancer cells is referred to as a T cell, like a T. And the T cell is a type of white blood cell. And most people don't know about T cells, but those are the cells that the AIDS virus kills. And you know, if your AIDS virus kills your T cells and you end up with a very low T cell count, you know bad things happen, usually infections. So the T cells are capable of killing cancer cells, but not in their native state. They have to be engineered. And it's possible to engineer your cells. And what's done with these T cells, which is the T in CAR T, is these cells are actually removed from your bloodstream. And for those of you who may be familiar with stem cell transplant, know that it's possible to remove specific sets of cells out of the bloodstream. You may be most familiar with stem cells being removed. But these T white blood cells, the cells that kill cancer, can be removed. But once they're removed, you can actually re-engineer them so that they'll actually recognize the BCMA protein on plasma cells and attach to the plasma cells and lead to killing. So this is referred to as immune-directed therapy because the immune cell is that T white blood cell that we all have, and the redirecting is attaching scaffolding. We put scaffolding attached to that white blood cell, and the end of the scaffolding recognizes the BCMA protein, the protein on the plasma cell of amyloid and myeloma. And what happens is it brings those two in very, very close proximity. And when they're brought together like that, the T cell, the engineering piece, and the plasma cell, it orchestrates cell killing. And it kills the cells that make the amyloid, stopping the production of amyloid. And in myeloma patients, it kills the cancer cell so that the body, the bones can heal. Well, the issue is it sounds great on paper, very exciting, but like all of these treatments, there are significant risks that one needs to be aware of before giving this consideration. When the white blood cell is brought close to the plasma cell to kill it, it activates the white blood cell, and that white blood cell activation results in the release of chemicals. And these are chemicals that are capable of killing the plasma cell, the amyloid-producing cell, the myeloma cell. But the release of these chemicals also produce a very, very profound inflammatory reaction in the body. When this happens and the cells start to die off, which of course is a very good thing, you don't want those cells, you want them dead, the release of the chemicals can produce serious complications and consequences. And it basically has an acronym, it's CRS. Also, not important. I think the important thing is that it results in extensive inflammation, oftentimes within 1 to 2 days of returning those re-engineered white blood cells to the body. And that inflammation can be quite serious. The inflammation commonly causes a fever, rapid heart rate, sometimes decline in blood pressure, sometimes reduction in your body's ability to oxygenate the blood. Sometimes it can cause serious problems with the kidney or with the liver. And in fact, this treatment, this CAR-T treatment, which is immune-directed to kill the plasma cell, 10% of patients end up in intensive care for support that can't be given on a standard hospital floor, where you need blood pressure support or special treatments which do exist to treat the inflammation before it gets too severe. But even with that, currently, mortality is associated with this procedure. 2 to 3% is what's typically quoted. And it depends on how advanced the process is and how much your organs are deranged going into it. But it's why, for most instances, this immune-targeted therapy is not a first-line therapy. It's not given before chemo. This is usually reserved for people who fail chemotherapy or even multiple different chemotherapy treatments because of this inflammation risk. And in addition to the inflammation risk, there can be neurological complications associated with this CAR-T therapy, usually 7 to 10 days after the treatment. The mechanism of these neurological problems are not well understood, but most commonly, people become forgetful, trouble concentrating, putting words together. There's a decline in their penmanship and their handwriting. Oftentimes, we come into the room to see our patients and we have trouble arousing them. We have to yell and scream to get them to wake up. These are serious neurologic complications. Occasionally, people can develop nerve damage that can lead to facial droop. Or patients rarely, fortunately, have been reported to have late Parkinson's disease. And all CAR T treatments carry what's called an FDA black box warning because there's an increased risk of second cancers associated with this treatment. So it's not, oh my God, it's immune therapy, it's natural, it's not chemo, I won't lose my hair, all of which is true. But it requires actually a very careful discussion with your provider specifically to talk about pros and cons and timing, and is it the right time? Is it a future option for me? When does one pull the trigger on CAR T treatment? CAR T is not the only immune-targeted therapy. There is another immune-targeted therapy, and the technical term for that is bispecific antibodies. And what those are artificially manufactured proteins that have two sticky ends. And one end is sticky to the T white blood cell, the cell that kills plasma cell, and the other is sticky to the amyloid-producing plasma cell or the myeloma cell. And so it brings them together, but instead of re-engineering the white cell, it actually has an attachment site stickiness to the white cell and to the plasma cell and brings them close together so they can be killed. It also produces pretty significant inflammation and sometimes neurologic complications. Anything that activates these white blood cells is going to result in the release of chemicals that can cause the fever, low blood pressure, fast heart rate, kidney, liver problems, and loss of ability to oxygenate the blood. All of these things may or may not happen, and they can happen in degrees. Very mild, that doesn't need treatment, moderate, that requires treatment, severe, that requires intensive care. And one of the great controversies that specialists in this area are currently facing is, well, they both sound like effective treatments. Well, how do you choose between the CAR T, the engineered T cell, and the antibody protein that is sticky to both the T cell and the plasma cell? And that's also a discussion with your provider because there are pros and cons. I'll start with CAR T. CAR T usually requires that you relocate to a specialty medical center, usually for a month or more. So there's what we refer to now in our specialty as time toxicity, time away from work, time away from your family, time away from home that is committed to being at the medical center. And it involves collecting the white blood cells out of your bloodstream through a specially placed catheter so they can be re-engineered. So that's part of this. A second part of this CAR T treatment is the engineering process takes 4 to 6 weeks. For most amyloid patients, it's not a major problem because the cells aren't growing very fast. But in multiple myeloma, sometimes patients have aggressive disease, and having a 4 to 6 week hole of no treatment while you're waiting to re-engineer those white blood cells, the T lymphocytes, well, that can cause serious problems 4 to 6 weeks. And sometimes you have to figure out how are we going to keep the lid on the multiple myeloma so it doesn't cause problems while we're waiting for engineering. There's another piece to CAR T. Before you can get your CAR T cells back, you have to have treatment to lower your body's immune system. Why is that? Well, those of you who've had a stem cell transplant know that you take out the stem cells and then you put them back in and they grow back. But with the T lymphocytes, once they've been re-engineered with that scaffolding, all of a sudden your body will not recognize it as belonging to you. And when you reinfuse it, your body's going to reject it if you don't do something about it. So before you can even get the T cells, you have to get additional treatment that lowers your body's immune system so the cells won't be destroyed when they're returned to your circulation. And of course, that can increase infection risk. In addition, it's very common after CAR T therapy for there to be low blood counts that can last a few weeks with transfusional support, much like patients who have stem cell transplantation. But the great thing that commends CAR T is that once it's done, and most patients will return home 30 days after, is there's no more therapy. You're done. You can be observed. And for those of you who've had therapy, that means no more dexamethasone, hallelujah. No more bortezomib and the risk that it's going to cause nerve damage in your feet. No more medicines that will make you nauseated. No more supportive care. You really are done, and you can be observed, well, indefinitely. There's no lid to it, and that is a great advantage. What about these bispecific antibodies, the proteins that are sticky at both ends? Well, one of the great advantages is it's off the shelf. It doesn't have to be specifically engineered, and it doesn't require that you have your white blood cells collected. Those are produced, put in a vial, like medications are, reconstituted and given back to you. And so in many instances, this can be done locally without having to relocate to another medical center. Although some centers will like a large university medical center to start treatment till you get past that inflammation part of it. They don't want to deal with or they're not experienced enough to deal with the fever, low blood pressure, and the changes and the management of that inflammation that occurs with both CAR T and the antibodies. But most patients will return home after a week or two, so there's an advantage there. And so obviously you can continue treatment at home, but there are two major disadvantages. One is this type of treatment with bispecific antibodies, or BiTEs, is ongoing. At this point in time, they're not time-limited therapy like CAR T, where you get it, and then 30 days you're done. It's ongoing, whether it's monthly or twice a month or weekly. It's continuous therapy in the current iteration. Will that change in the next couple of years? Possibly, but for right now, it's intended for ongoing therapy. That's one. Number two is there's a pretty substantial infection risk associated with these antibodies. And a lot of work that's currently ongoing is trying to figure out how do we try to prevent infections in our patients? What are the right supportive care, antibiotic prevention, so that these infections don't occur? Some of the infections can be quite exotic. They're not your typical bacterial germ where you take penicillin, amoxicillin, or something like that, and you're done with it. They can be serious and trigger hospitalization. So you see there's pros and cons for both techniques. And again, you're not going to figure out what's best for you on this video. You really need to have a discussion of the pros and cons and merits, what can be done locally, and what your personal preferences are when comparing these immune-targeted therapies, CAR T and bispecific antibodies. Thank you for your attention. Have a wonderful day.